My name is Hope Newport. I'm the Family Services Manager at the International FOP Association. And thank you for joining us for today's Family Services webinar, Feminine Health Issues in FOP. So I wanted to start by just going over a few specifics of the Zoom platform. You'll notice that you do not have video or audio. So in this webinar format, everyone is muted and there's no video just to prevent any background noise or distraction. That doesn't mean we don't want to hear from you. We would love to still answer your questions. So to make sure that the panelists and I see all questions, please use that Q&A button. So if you scroll over the bottom of your screen, you'll have a black toolbar pop up and there's a Q&A button where you can drop your questions for the presenters, and you can feel free to submit those throughout the presentation. If it's very on topic, we'll try to stop and answer it there. But if we hold it till the end, we might need a little more time to answer it. So we will also be doing Q&A at the end of the presentation. If you have any sort of technical issue, please feel free to reach out in the chat and I'm happy to answer or help you with that. And I know we've had a few people already say hello there from Germany and Serbia. So if you would like to just connect with the other community members on the call, please feel free to do that in the chat as well. And then lastly, I just wanted to remind everyone that today's webinar is being recorded. Doctors Mukaddam and Park were very wonderful, and they're going to be sharing slides. So there'll be a PDF of slides from today available along with a recording by early next week. So we are going to get started now with introductions. And I just want to start by saying that first, I'm extremely grateful to these two women for taking time out of their busy schedules to shed some light on what I know is a very important issue in the FOP community. So you may be familiar with one of them. Dr. Mona Al-Mukaddam is an assistant professor of clinical medicine and orthopedic surgery at the University of Pennsylvania and the director of the Penn Bone Center for the Division of Endocrinology, Diabetes, and Metabolism. So Dr. Al-Mukaddam is board certified in internal medicine and endocrinology, diabetes, and metabolism. And some of you may also know her. She may be familiar as she's the principal investigator on ongoing clinical trials in FOP. And she's also an Ian Kelly Clinical Scholar at the Center for Research in FOP-related disorders at Penn. Dr. Al-Mukaddam has been a member of the community for some time now and is a founding member of the International Clinical Council on FOP. So we're so grateful that she was willing to kind of lead the charge on this, and in doing so, and in shaping today's webinar and wanting to bring, the best education and content, she brought in the expertise of a true gift to the FOP community, Dr. Beu Park. So Dr. Park is a minimally invasive surgeon in gynecology at Jefferson Health. She's a board certified obstetrics and gynecologist, and in her time at Thomas Jefferson University Hospital, she has worked closely with Dr. Al-Mukaddam and the team of FOP experts at UPenn, including Dr. Kaplan, but also Dr. Zvi Grunwald, who's the anesthesia expert in the FOP community, to help provide care for multiple patients living with FOP. So I'm going to stop talking now and let the experts take on the rest of the subject for today.
All right. Thank you, Hope, and the IFOPA for inviting us to give this webinar. But really, the true thanks is to Dr. Park for joining me today to help me answer some of the questions that I've been getting from you, from the FOP community on a regular basis. And I'm hoping that we will be able to answer some of your questions, but also to shed light to a lot of things that we still don't know and we're still trying to learn, and also to learn from you what you have found to be effective and helpful. So in this presentation, I'll be going over some hypothetical cases. So these are not real cases, but trying to highlight some of the questions that you have asked me in the past. So the first case is of a 25-year-old female who has FOP. She was diagnosed at the age of 12 years. And she has primary amenorrhea, meaning that she never had a period or a menstrual cycle. Her disease has been relatively quiet. Her last flare-up was 12 months ago, and she did receive a short course of prednisone, but otherwise she's not on any chronic medications. She has some secondary sexual characteristics, meaning that she had normal breast development, and she does have some axillary and pubic hair, but she does not have any menstrual cycles. before I go over to Dr. Park and ask her my questions, I'm just going to kind of define what is amenorrhea and what is the difference between kind of primary and secondary amenorrhea. So primary amenorrhea is when you don't have menstrual cycle or there's absence of menarche by the age of 15 or over. So average age of menarche is about 11, 12. It's normal for some to be, it's normal to have some variation. And so up until the age of 15, we usually don't start doing any evaluation as to why someone doesn't have a menstrual cycle. But after the age of 15 and over, then we start to want to investigate further, why hasn't the menstrual cycle started yet? And some of the causes of primary might be slightly different from secondary amenorrhea, but a lot of times they're very common. So secondary amenorrhea is when the period started initially. So someone was getting regular menstrual cycles, and then the period stopped for 3 months. Or it could be if someone does have a menstrual cycle and the menstrual cycle is not very regular, so it doesn't come every month, but then they have a period of 6 months of when they don't get their period. And so if that were to happen, usually we do start investigating, why is this happening? Why is someone having amenorrhea? So with those two definitions in mind, I just wanted to go over to Dr. Park and ask, what other information would you need on our patient with primary amenorrhea?
Yeah, and before I answer those questions, I want to just quickly say I'm so thankful to be here. I would have the opportunity to work with Dr. Mo and Dr. Kaplan on a few of our FOP patients who required surgery, which by no means makes me an expert, but I'm happy to learn about the community, learn about the needs, and help in any way I can. And so going back to our case, what more information would I need? You know, a period isn't just within the uterus. The whole system actually starts from the brain, as you can see on the picture on the right. It starts from the brain, sending signals to other parts of the brain that then sends hormonal signals down to your ovary saying, hey, make these hormones, and make them kind of work together to make a period blood every month and shed it every month. So it's actually a complicated system. And to know where there may be a problem, if there is a problem, I'm going to ask questions that kind of start from the top and go all the way to the bottom, just so I can gather more information to see if we can get a better idea of, you know, where we might need to focus our evaluation. And so, yeah, it's okay. On the list, it actually goes kind of from bottom up in terms of going from head down to the uterus. And so I might start from the top and starting from the pituitary and the hypothalamus, which are two areas in the brain that starts with these hormones, with these signals, and it's a little bit more generalized up there, and it gets a little bit more reproductive specific down in the uterus. But I might ask, do you have any, you know, symptoms related to thyroid disorders, you know, mood change, weight changes, sudden weight gains, or losses or hair losses, things like that? Are they on any medications that might be suppressing it from up top? Some medications can have those side effects because they start suppressing from up there. And then we can kind of move down. If that's all okay, you know, then I want to know, is the ovary producing those hormones that it's supposed to make? And the ovary makes both male hormones and female hormones, and they convert it from male to female. So I'm going to ask if there's any symptoms that might indicate there's a lot of male hormones that are not getting made into female hormones. So are you having like facial hair growth or a lot of acne or maybe chest hair? Things like that might indicate, hey, there might be a lot of testosterone that's not getting converted to estrogen. Or maybe all of that is okay. And maybe the issues are a little bit lower down in the uterus. Maybe you are making the period, but for whatever reason, it's not coming out of the uterus. Maybe there's a block. And so most commonly might be like an imperforate hymen. So that might be something that just doesn't allow the period blood to come out of the uterus. And so if that was the case, maybe you feel monthly cramping, like you're gonna have a period, but you just don't see the period blood. Or you might have the monthly symptoms that women can have right before their periods, like their breasts get tender, or they have mood swings, stuff like that. So these are all signs that, okay, your estrogen and, you know, your hormones are kind of doing what it's supposed to do, and maybe you're making the period, but it's just not coming out. Some things that I can also block that outlet might be adhesions in the uterus. So people who've had surgeries in your uterus can have some scarring. So that is another way that maybe the block can happen within the uterus. Rarely, you can have an absent uterus, meaning you don't have a uterus and you were never born with it, but we wouldn't know until it's about time of menopause and when we would expect the period to come. So again, more rare, but the point is there's a whole system from brain all the way down to the uterus. And it's sometimes not easy to just say, oh yeah, you're not having a period because of this. We kind of have to see where in that whole pathway is there an error, or maybe the whole pathway is okay, but certain conditions or certain in your conditions that you might be in might not allow you to ovulate. So for example, athletes who are just training and their body is under constant stress, or you have a chronic illness and for that reason your body's under constant stress, or you've lost a lot of weight and you're nutritionally not at a healthy level, your body knows like, hey, maybe not right now is not the right time to get pregnant and start a pregnancy when your body's already going through all this stress. And so those are the things I would ask. Have you been going through stress lately? You know, any activities that might be causing that kind of stress that tells your body to, you know, stop ovulating. Right now is not the time to get pregnant. So those are some of the questions that I would ask.
Yeah, thank you. This is exactly what it is. It's never straightforward. It's so complicated. There's a lot of things that could be involved. But in terms of our patients, so, you know, you talked about those pituitary hormones that kind of are released from the pituitary that act on the ovaries. And so those are the FSH and the LH. So that FSH and LH in our patient were on the low normal end, as the estradiol, which is the estrogen produced by the ovaries. So that suggests that maybe this is something that was what we call hypogonadotropic. Hypogonadism, meaning that there's not enough FSH and LH being produced to stimulate the ovaries to make estrogen. Our patient also underwent pelvic imaging since this was primary amenorrhea, and she did have a uterus, and there was really no evidence of an outlet obstruction, like you mentioned before, that, you know, the period, if she was to get periods, they should be coming out. Also, an MRI of the pituitary was done, given that we do know that, you know, pituitary abnormalities are things from the brain that are signaling the ovaries what to do, could be involved with such conditions. And so she did have an MRI of the pituitary that was normal. And she also had normal thyroid levels, a normal prolactin, and normal testosterone levels. So with that being said, Dr. Park, can you think about what are the potential treatment options specifically for our patient and maybe for other patients that have other common causes of amenorrhea?
Yeah, and so obviously in general, it really depends on what the underlying issue is and you want to focus on that. But for a patient who is, you know, either not making hormones or not ovulating, we can replace those hormones by giving them estrogen and progesterone, because it's important to have those hormones, not only just to have a period, but those hormones are good for your heart and your bones. So we can replace that if we know that that's where the issue is. And the easiest way to replace that is to try birth control pills, which have both estrogen and progesterone. And we know that that is okay and it's safe for use in FOP patients. But anytime we're giving anything with estrogen, there is a slight increased risk of blood clots. That's one of the risk factors that we always want to monitor. And we want to make sure you don't have any risk factors already apart from that, because if so, that may not be an option for you. But we would counsel patients saying, hey, look for signs of blood clots. Usually that happens in your leg, one leg or the other. One might get swollen, red, or tender. And of course, if that ever happens, you should stop your you should stop your birth control pills. In other cases, if it's a case of an outlet obstruction that we talked about, that is most likely going to require surgical intervention to open up the obstruction. And like we've mentioned, if it's not a hormonal thing, if it's not a structural thing, and maybe you have a chronic illness or something else like PCOS, then we would address that separately.
Great, thank you. So I don't see any questions in the Q&A right now, so I'm going to move on to the next case. But if you have any questions, please post them in the Q&A and not in the chat, because I'm not monitoring the chat as closely. All right, so then going over our second hypothetical case. So this is a 24-year-old female, also has FOP. Her disease has been significantly more active, and she's pretty affected by FOP. Both her shoulders and elbows and hips and knees are fully ankylosed. And so mobility is really an issue for her. and even going to the restroom and is an issue for her. She has been getting her periods, so she's getting her periods somewhat regularly, but almost every 5 to 7 weeks, and they're usually heavy periods. And she's coming asking about what are things that we can do to decrease the burden of these monthly cycles, and also potentially assist with easier hygiene. So, Dr. Park, are there any medications that we can safely use to decrease or stop a menstrual cycle?
Yeah, and before we, just start any women on medications or particularly hormones, we always want to clarify what the goals of treatment or goals of therapy are. And so for this hypothetical patient, if the periods are coming every 5 to 7, they're heavy, maybe it's not about, it's important to be able to predict when it's going to come. Maybe you want it exactly every 4 weeks, when it's going to come. It's not a surprise when you're out, doing your things. Or maybe it's reducing the duration or frequency. Maybe it's too heavy and we want it just lighter. Or maybe if someone's having a period every month, but that's already too much, we can always change that to spacing them out. Maybe you want it every 3 months, or maybe you want to make sure you kind of skip periods when you're on your vacation or something. So that's all possible. So we want to know what the goals are. Other cases, maybe it's the menstrual related symptoms like PMS that's bothering you. Maybe, the mood swings, or some people get migraines right before their periods. And those are the things that we want to minimize. Or maybe the woman's goal is to have amenorrhea, which means have no periods at all. And that can all be done safely. And just to clarify, we talked about the first case where amenorrhea, not having a period on your own, that's not ideal. That may mean that you're building up the period blood in your uterus every month, but you're just not shedding it. We don't want that. We don't want you to just keep building up period blood. But if we have no periods because we're suppressing it with hormones, that's okay and that's safe. So I just want to clarify those two distinctions. It's not okay just to not have a period on your own, but it's okay if we're forcing that or making that happen with suppression. And we can move on to the next slide.
Yep.
And so because periods are regulated by the hormones in your body, the way we manage it is often also by hormones. And if you've already talked to a doctor, the first thing that they might mention is just a standard birth control, which has both estrogen and progestin in it, mainly because it can be the easiest way to sort of manipulate your periods. Like I said, if you wanted to have a period every 3 months, yes, she's pointing to the pills on the bottom. You just take the active pills and you can move on to the next packet with active pills instead of taking that oddly colored row, which is, there's nothing in those pills typically, and it's called the placebo row, and that's when you would have a period. And so it's okay to kind of move on to the next packet, and your doctor might say, well, do it every 3 months and have a period. Or you can just kind of continue just with the active pills so that you don't have a period. One thing about the birth control pill with estrogen suppresses your own estrogen from going up and down every month. So it just keeps it at a very constant level. And so I've mentioned people with PMS where they have those symptoms with those fluctuations. This might be one way to avoid it, to avoid those hills and valleys of hormones going up and down every month that you might be sensitive to.
Dr. Park, can I ask one question?
Of course.
So is it important that they have a period, or is it okay not to have a period at all? And what are the potential concerns of not getting a period at all while you're on the pills?
Yeah, so while you're on the pills, it's safe to not have a period at all. Like I said, the way it works is it suppresses the lining from building up, like the uterine lining from making the period blood to begin with. So it's okay to not have it because you shouldn't have anything in there to shed out. Having said that, in the beginning, when you start to space them out, like every 3 months or a year, however, in the beginning, one side effect might be that until your body sort of adapts to it, you can have what we call breakthrough bleeding. So until your body kind of adapts to it, your body's still trying to like make a little bit of hormones, or at least, get used to it. You can have some breakthrough bleeding, which is sort of unanticipated, usually light bleeding, which might be very, bothersome for you. So you may not want to start out with just taking it continuously from the beginning. Maybe you want to start out with 3 months, kind of get used to it, and then space it out in time. But again, on suppression, it's okay to not have periods. We also talked about the risk of blood clots. Again, that risk is low for most women without other risk factors. We always say like getting pregnant, increase your blood clots even more because your estrogen just shoots through the roof when you're pregnant. But there are other conditions, medical conditions or certain medications that if you're taking, you shouldn't be on an estrogen containing product. So that's something very important to discuss with your doctor. And then those combination of hormones also come in other forms like the patches or the vaginal rings. And that might be more ideal if you don't want to take a pill every day. Some people just aren't good with remembering to take pills. So if you want to do something every week or every month, those might be options. Obviously, a vaginal ring might be more difficult to insert, especially if you have limited mobility. But if you do, and if again, you don't have to think about something every day and you just need to change it out every month, that's another option. But those are the same hormones that just come in different forms.
And so Dr. Park can usually, in people who don't have limited mobility, they would insert the vaginal ring themselves, right? They could do it themselves. They don't need to go to the doctor's office to do that. Okay. Right.
They come in little packets and they almost look like, I always describe them as like little hair ties that women usually have on their wrist or something. And it's plastic and about the same size and soft, and it just goes up in the vagina, and then they just take it back out if they can. Yeah, at home.
Yep. Thank you.
And then there are pills that are just progestin only. So they often are not birth control pills, but sometimes they're tolerated a little better because with estrogen and progestin, a lot of the hormones, the other side effect is that it's not tolerated well. Some people are very sensitive to those hormones. Some people get headaches with them or nausea or bloating, and for whatever reason, they just don't like it. So another option might be trying something that's just progestin. So estrogen is the hormone that sort of builds up the period blood in your body, but progestin is the one that sort of thins out the lining of the uterus. So on progestin only, your hormones will still do this every month. It'll try to build up the period blood, but the progestin will try to stop it within the uterus. And so that's how that works. And that's how we use it to try to either lighten up the periods or get rid of the periods, but it won't, if you do have periods, you can't time it. You can't time the predictability. It'll just come when your body normally makes them. You can't manipulate that.
Dr. Before we go over the IUD, I just want to talk more about the progestin only pills.
Yes.
So it seems, the benefit of progestin only pills over the combined estrogen progestin is, like you mentioned, the potential side effects with the estrogen levels. But also potentially would this also decrease the risk of having blood clots if you're on progestin only pills?
Right. So because it doesn't have the estrogen, it doesn't increase your risk of blood clots.
Blood clots, yeah.
Exactly. So if you had a contraindication to the estrogen, that might be another better option.
Okay. And then the other question that I have is, and you have it here, that it's important to highlight that if you're on progestin only pills, that even if you're not getting your periods, you could still get pregnant, and it doesn't offer contraception.
Exactly.
But other than that, it seems to me like the progestin only pills might be an ideal solution. Why doesn't everyone take progestin only pills?
We actually use it quite a bit. We use it quite a bit, but I think a lot of women also just want that contraceptive benefit. So, they don't want to be on something and like two different things or, yeah. And the one other benefit of progestin is we can always start low and kind of increase the dose as needed for the women. But the other side is, because your own hormones are still doing this and the progestin is just trying to counteract that, you may still have some breakthrough bleeding if your own hormones still, like your estrogen goes high and you still make it. So.
And I know that with progestin, like implants, there's some concern about bone health and, because it decreases your own body's production of estrogen. Is there any concern with the progestin only pills?
No, that is with a depot injection, which I know is not recommended for FOP women to begin with, because that's an intramuscular injection, because that's a very high dose that we give at once. And that's what suppresses the estrogen, but a regular progestin pill will not do that.
Would not do that. Okay, that's great. Thank you.
Yeah. And so, I wrote the progestin IUD in there, and we'll talk a little bit about that. But, if you don't even tolerate the progestin pills, maybe even that hormone is too much for you, one consideration could potentially be a progestin IUD, which does all the things that I just talked about with the progestin pill, except you don't take it by mouth, so it doesn't go through your whole body. So there isn't a tolerance issue. It just stays inside the uterus. And if it works well, it can last up to 7 years, which would be great if you don't have to think about something and you don't have any periods for 7 years. It does induce amenorrhea, which means no periods, in about half of women. And for most women who continue to have periods, can have very light periods. Of course, for I think our FOP community, we always have to be mindful of the mobility issue of the lower extremities. Are you mobile enough for us to insert it? We insert in the office, but we do have to be able to place a speculum in the vagina. And even if it goes in fine, is there any concern for losing mobility in the future where when we need to take it out, is that going to be an issue? So if this is an option for you and you want to try it, I would say, when we put the IUD in, there's a string that hangs out of the cervix so that when we take it out, we pull the string. That's how we do it. And we always trim it kind of short. But if there's any concern for taking it out in the future, I would, talk to your provider about leaving that string longer so that if something comes up, it would be easier to just find that string without doing a full, speculum exam and removing it if needed.
And when I was asked about IUDs in the past, we would talk about, what if there's a complication and the IUD can, perforate or migrate, and that would require a more invasive procedure to get that out.
Right.
How common is that?
That's actually not common. I know it's probably commonly read about because, like most things, people will talk about it if they've had a bad experience with something. So it's very rare for a well-placed IUD to just start migrating on its own out of the uterus into the pelvis. So the theory is that it's probably, if it does happen, it probably happened at the time of placement and the provider just didn't know it. They were probably a little aggressive or didn't go in the right place and then deployed it, and we never knew until we checked for it later. So that's a great point, because we talked about this, that if you do get an IUD, I would also recommend just getting an ultrasound at the time of placement to know that it's in the right place. And after that, the risk of migrating is really, really low.
Great. Thank you so much. That was very helpful. So I see two questions in the Q&A right now that I think is appropriate for us to actually address them right now. So one question is about, what is your opinion on phytoestrogens?
I guess that's a good question. For what, right? Phytoestrogens, I don't think it's going to give the same effects of controlling bleeding or manipulating periods like we just talked about. It's probably nothing, and there aren't any studies or studies trying it, but it's probably not at a high enough level to actually override your own body's estrogen system and just suppress it all.
Yeah, I think the times that I've heard people take like the phytoestrogen is more for menopausal symptoms,
right?
Where they want to take some estrogen, but maybe not the higher doses where you worry more about the side effects of breast cancer, blood clots, and other things, where they try to say, and it's a more natural,
right.
more natural way of doing that. But yeah.
Right. And that's the same thing. And I'll say for women who are going through hot flashes related to menopause, I can say try foods that are more high in like estrogen, like products like soy products, things like that. And that's all okay to try, but it's never going to be high enough to actually stop periods on women who are menstruating. Yeah.
Thank you. That's it. So basically we think that if this is phytoestrogen probably is going to be safer or lower doses of estrogen than what we usually give, but it wouldn't be enough to treat abnormal bleeding or any of the other symptoms that you might experience.
Right.
So there's another question asking specifically about Nexplanon, about putting Nexplanon, and what do you think about that if it goes under the skin?
Yeah, and I actually wanted to talk to you about this too, because we kind of discussed it right before, but I also remembered it is actually subdermal, so it's right underneath the skin. It doesn't actually, it's not intramuscular, so it's within the fat right underneath the skin. Yeah. Having said that, and you can tell me if that's okay or not for women with FOP, but for contraception, great. To prevent pregnancies, that's great. In terms of bleeding profile on the implant, we typically say it's about 30-30-30. So 30% will have regular periods as they always did, and it won't affect it, which for some women, that's fine. 30% will have irregular bleeding, which is not ideal. And then 30% will have very light or no bleeding. So for like a 30% chance of getting what you want, which in this case would be lighter periods, I feel like it's not the best option, but certainly an option.
Yeah. And, usually subdermal or, that should be okay. But can you go over more the procedure of how you insert it?
Yeah, it's a procedure in the office, so you don't need like a special, anything for that. We just numb the area with lidocaine, and it goes in with like a sort of like a larger needle that has the implant in it, and it just slides underneath the skin and then comes right back out. So the procedure itself is 10 minutes under local anesthesia, and you don't have any restrictions. You have a little Band-Aid for 24 hours and that's it.
Yeah. So I think this is a very good point. So it's good for contraception. It's potentially can be used in FOP. It's not directly affecting the muscle. However, the needles are significantly bigger, and there is a concern that a flare-up might occur with that. And the retrieval of that would be also requiring a small surgical cut and removing it. So it is superficial, but it is a slightly more invasive procedure that could potentially be associated with a flare-up. So if we can have alternative options, that might be a better option to do that, especially if we're trying to address heavy menstrual cycles at the same time.
Right.
So someone asked also, what is phytoestrogen?
That's a good question. Phytoestrogen, it's probably like estrogen-like products, but things that are not technically FDA approved. It's a very broad term that can incorporate a lot of things that are unregulated. So it's kind of hard to tell you exactly what it is, but it's essentially naturally occurring products that can mimic estrogen-like effects.
Yep, thank you. There's one question that I'm gonna table it till the next case because it is related somewhat to our next case. But thank you all for these really great questions. Okay. So, and then other medications that are non-hormonal.
Yeah, so I just want to briefly mention this, and one question I have for you. If some women just want to avoid all hormones altogether, which is okay, and even ibuprofen, a high-dose ibuprofen just taken during menstrual cycles can decrease the flow and obviously help with the pelvic cramping associated with bleeding. There's one medication called tranexamic acid, which can reduce menstrual bleeding. And this is what I wanted to ask you about, if this is okay for women with FOP. It's a anti-fibrinolytic, which means it kind of promotes clotting in your body. So like, for example, if you had a cut, it makes it clot faster so you stop bleeding quicker, which is what's happening inside the uterus. Of course, that comes with risk of making clots where you don't want to make it. So the contraindication is women who've already had blood clots somewhere or had strokes or stuff like that, they cannot take it, but it's similar to the estrogen. So I wanted to bring it up to you if that would be an option for women with FOP.
Yeah, so in terms of the risk of blood clots, this is definitely a risk in our patients, just because usually they have less mobility. And so it is something that we are concerned about. We do use estrogen, and for the most part, we've been able to use it safely. So if you think that the risk of blood clots is not going to be higher than estrogen itself, then I would say that it's completely fine to use it.
Right.
I do have one interesting question for you. So regarding the non-steroidals, we usually worry about, increased bleeding usually. Before procedures, we tell patients usually to hold taking non-steroidals, but here you say that it can decrease the menstrual flow and menstrual cramping.
Yeah, you're right. Yes. And I'll be honest, I don't exactly know the mechanism behind it, but I think it does have a little bit of vasoconstrictive properties in the uterus, meaning the blood supply to the uterus that, give all the period bleeding, it kind of constricts them. So it does help with that. But yes, it's okay to take and it doesn't increase it.
That's very good to know. Thank you. And so before we move to our next slide, I really want to just give you a highlight to Karen's hard work in doing this ability toolbox. And so if you go on the IFOPA website, there is a link to multiple tools that can be used to assist with your day-to-day life, but also specifically with kind of hygiene, where you can have certain tools that can help with toiletry and wiping, and also you could use a mirror. So there's a lot of information on there, and so please go ahead and refer to that and email Karen if you have any questions on how to obtain these specific tools. All right, and so I'm going to move to our third and last case, and then we can kind of open it up for more Q&As. I know there's one that is still pending that I'll answer after our third case. So this is a 34-year-old female with FOP, and she was diagnosed with a large uterine fibroid on evaluation of irregular and heavy menstrual cycles. The uterine fibroid is causing some abdominal discomfort, but it seems tolerable. And the bleeding is really not that bothersome. So before I hand over the questions to Dr. Park, I'll just go over on what is a uterine fibroid, or what we call leiomyomas or myomas. And so they are the most common pelvic tumors in females. And Dr. Park can correct me on these things, but the prevalence really can range from anywhere from 7 to 80%. And it really depends on whether you're looking at studies where they're looking at people with symptomatic fibroids, where you'll see that the percentage is much lower, or if you're looking at autopsy studies where this is, regular autopsy studies, and they noted that a lot of people have fibroids. And so the prevalence seems to increase with age, but it could range anywhere from 7 to 80%. So it's really common in the general population. And it's basically abnormal growth that can form in the muscle of the uterus. And it could be in several locations, and a patient could have multiple fibroids, and those fibroids could be in multiple different locations in the same patient. So it could be submucosal, which is seen here. It could be intramural, which is in the muscle, and then it could be subserosal, which is just basically outside of the uterus cavity. It is important to note that this is not cancer, but it could change in size with time. And in terms of symptoms of fibroids, as I mentioned, a lot of looking at the prevalence data where they say 80% of patients have uterine fibroids, majority of them were asymptomatic. So really most of the fibroids cause no symptoms at all. But when they do cause symptoms, they can cause heavy periods, pain, pressure, or feeling of fullness in the body. The feeling that you need to urinate often because of the fibroid compressing the urinary bladder. And so you have less capacity in the bladder to hold urine. So you need to go to the bathroom more often. But also because it can cause constipation and decreased bowel movements because it can compress the bowels. And in people who are interested in getting pregnant, this could affect the ability of someone getting pregnant. So Dr. Park, for this patient specifically, or just in general, when someone has uterine fibroids, do you really have to do something about it as soon as you find out?
Absolutely not. Like you said, it's not cancer. So if it was cancer, I would say you have no choice. They got to do something, but this is not cancer. And so treatment often varies just based on symptoms and what the patient really wants. And so the things that we consider, as mentioned here, one is age. If we just happen to see some small fibroids, it doesn't bother you, or maybe it bothers you a little bit, but you're going to head into menopause soon. Maybe it's okay to just monitor and observe, because fibroids do grow with estrogen stimulation. And when menopause hits, your estrogen levels go down. And so oftentimes fibroids will shrink, not away. They don't go away completely, but they will shrink. And at that point, you'll probably also stop having periods. So maybe your symptoms will be okay. So that it may be okay to monitor if that's the case. If the fibroids are affecting pregnancy or may affect pregnancy in the future, that's a reason definitely to address it, especially if it's what Dr. Mona kind of showed, the submucosal one right in the cavity where the pregnancy would happen. Even if it's a small one, you might consider getting that removed if it's going to get in the way of pregnancy. If the symptoms are so severe, you're bleeding so much that you are getting anemic and you're requiring iron or blood or anything like that, I think that's definitely a reason to address it, because anemia is also not healthy for you. Like we said, you can have a lot of fibroids. They can vary in location and size. So depending on all of that, we might make recommendations. If you have 2 very small blueberry-sized fibroids in the middle of your uterus, I would say don't worry about it, leave it alone. Some grow to the size of melons, and we often use fruit analogies. In this case, I would say, yeah, let's consider doing surgery or taking it out. But we really have to weigh your symptoms, how you feel about, what each of these interventions might mean for you. And especially for FOP women, surgery is going to be more risky. It's definitely doable, but, we have to really weigh that. One other thing I would add for our patient population here is, I think it's important to sort of always think about maybe 5 years out, or, how are things going to change? Like what's happening with your FOP condition versus what's happening with a fibroid. Maybe it's not huge now, but we know that over the past 3 years it grew doubled or something. Is that something we should consider? What might change in the next 5 years, and is that going to be better to just address it now, or should we wait? So I think those things are important, always kind of thinking ahead.
That's a very good point, Dr. Park. I think it's with the respiratory issues and the jaw locked, or different issues, and maybe sometimes it is better to consider treatment earlier rather than waiting, even though we are usually super duper cautious and we always say, don't do surgery, but I mean, we have, But as we learn more and we gain more experience doing these procedures, then maybe that algorithm will change.
Right. Because for other people, sometimes if they need emergent surgery, it's okay. And I could do it in the middle of the night by myself or whatever. But that is not something you want for this community, you know?
Nope.
And so you never want it to get to that point where we have to act urgently or emergently or anything like that. So I think it's always just important to just think a few years out and, you know, in preparation for that.
That's a very good point. Thank you. And so if someone does decide, all right, you know, I'm having symptoms and I'm very bothered, what are the treatment options?
Yeah. And so if the symptom is mostly bleeding, we can use medicine. And we talked about a lot of the hormonal options or even non-hormonal options that might help with the bleeding. There are no medications that we recommend to just decrease the size of the fibroid. We'll talk about a few that can temporarily do that, but nothing long-term that says, oh yeah, keep taking this and your fibroids will go away. We don't have anything like that. In terms of decreasing the size or getting rid of fibroids because maybe you have what we call those bulk symptoms, it's causing a lot of pressure, it's pressing on your bladder, it's pressing on your rectum, stuff like that, then we would consider surgical removal, and we'll talk about sort of options in the next slides. Another procedure that's not a major surgery is called a uterine fibroid embolization, which is a procedure that a radiologist will do. They will make a small incision in your groin or leg, follow up the vessels and find the ones that supply your fibroids and close off those vessels that supply the fibroids to shrink the fibroids. That is an option, but we've kind of discussed before that there aren't any experiences in FOP women that we know of. It does require sedation. It's not a definitive management. And so maybe it'll work, maybe it may not, and you will have to have a second procedure. Those are things to consider for us.
Yeah. And we have had our patients, you know, given that option of maybe doing uterine embolization. So thank you for mentioning that. And so in terms of medications as well, what do you think is safe in FOP?
Yeah, so we talked about all of the estrogen and progestin options. I just wanted to briefly mention sort of the next line medications, which are called GnRH agonists or antagonists. So we talked about the system starting from brain down, and all of the hormones kind of start at the ovary and uterus levels. But then the GnRH hormones are the ones that start at the brain. They kind of suppress things from higher up, and it is a little bit more aggressive. And so there are some out there, you may have heard some commercials about pills called Oralissa, and there's a new one called Orion, and maybe even some older school ones called like Lupron or Zoladex. And there are different indications for this. So sometimes we need stronger suppression for women who may have endometriosis or other things. Having said that, this is not long-term options because this is essentially putting you through menopause, like medical menopause. We're just shutting down everything. And like I said, your hormones like your estrogen and progesterone are needed for your body, for your bones and your heart. So we can't just do this indefinitely. More than that, it's because it's essentially inducing menopause, the side effects are pretty severe. It's the hot flashes, the mood swings, you can't sleep. And for that reason, most people can't tolerate it long term. And they're also not recommended to be used more than 6 months to 2 years, depending on which one you do. But they may be options, they may be temporary options. And I wanted to, mention or ask if this would be safe in FOP patients.
Sorry, you were asking me a question?
Yeah, just that would this be safe to use,
So you mean in terms of the GnRH agonist antagonist? I think, in terms of safety wise, as you mentioned here, 2 of them are actually in a pill form, and one of them is subcutaneous implant, and subcutaneous, injections are fine, and pills are usually fine. I think going back to the same point that you mentioned before is what to anticipate in 2 years, 3 years. What is the ultimate goal? And since these medications cannot be used long-term, and they're not going to affect really the size of tremendously, if size is a huge issue, is it better to address it now and not kind of delay these issues again?
Right.
There is one question that we have in there, which is definitely related to some of the slides. So I just want to mention them here. If someone's has uterine fibroids, and they're causing some, symptoms where they need to urinate quite frequently, like an urgent need to urinate, and they're also going through menopause and bad symptoms, but they don't want to take estrogen either because the concern of the estrogen kind of stimulating the uterine fibroids. So how do you counsel patients with, fibroids that are large, and then giving them estrogen? Are you concerned about this estrogen increasing the size of the uterine fibroid?
Yeah, so it can. So I mean, we say menopause, it might shrink. So if you're nearing menopause, we'll just keep giving you estrogens, and it could potentially just continue to grow as if you're not in menopause. In a case like that, where you might have some urinary issues, I think it's important to check the bladder separately, because there are also bladder conditions that can cause urinary urgency or frequency and things like that. So you want to make sure there isn't something separate. It's important to know how big the fibroid is, because if you have fibroids, but it's like, like I said, a small blueberry size, that's probably not big enough to press on your bladder, which sits right in front of the uterus. But if you have something that's like 10 centimeters or larger, that can definitely press on the bladder and maybe causing your symptoms. In which case, like I said, there's no medication that kind of shrinks it. If you're close to menopause, you might consider going through it and seeing how much it shrinks to see if that improves your symptoms. Or you might, if it's, 10, 15 centimeters, and I don't think it's going to shrink down to not giving you any symptoms, and you would have to consider possibly surgical intervention. But I think it's important first to make sure there isn't a separate bladder condition that's causing those symptoms. I probably wouldn't give estrogen in that scenario because it'll probably just make it worse.
Yeah. And I think sometimes for some of the menopausal symptoms, there are non-hormonal options as well. Sometimes they use like SSRIs or...
Yeah. So for symptoms of menopause, like the hot flashes or the mood swings or something like that, there's ways to manage it without hormones. So medications that are originally prescribed for depression, like antidepressants, some have been shown to be effective in reducing hot flashes and the mood symptoms and stuff like that. So that's a very safe option to take, especially if you have fibroids. There are other second, third line medications too, but usually one of those medications would be the next step after hormones.
Yeah, thank you. That's a very good point. And it's very important to also look at other causes, right? Like not just say this is the uterine fibroid.
Right.
It's very important to look at that. So then in terms of surgical interventions, what are your thoughts on that, especially within our FOP community?
Yeah, and I would say for that, I think all procedures can be done safely if you have the right team that is very aware of the FOP community and the challenges and the risks that are there. And so to briefly go over some procedures that are available. So there's something called a hysteroscopy, which is a small camera that goes up inside the uterus. And so if you have a tiny fibroid in the cavity up there, this is a very non-invasive outpatient procedure where we could go in and kind of resect out just that little fibroid. And there isn't much recovery time to this. The procedure may take 30 minutes, so that's one option. Myomectomy is where we go in and take out the fibroids from the uterus, and that's important for women who want to preserve their fertility, preserve their uterus, but need the fibroid removed for their symptoms, but knowing that it can always come back as long as you preserve the uterus. Hysterectomy is taking out the whole uterus with the fibroids together. It does not mean taking out the ovaries where you start having menopausal symptoms or any changes in your hormones, but that is a definitive measure where the fibroids obviously can't come back. We also, in general, offer laparoscopy for all of these surgeries. So the fibroid removal or hysterectomies. To my knowledge, I don't think there's been any laparoscopic procedures for women with FOP. We can, if that ever comes up, we would talk about that, but those are some of the options. But the most important for our community, I think, is that you have a team, and it's a big team, even for like a very straightforward surgery, it's a very big team that takes a lot of coordination. It starts with, Dr. Mono and Kaplan managing the steroids before we even, start anything. Our anesthesia teams are very specialized. They can't just flex the neck to intubate somebody. So they have to go through a camera to be able to intubate somebody. When I do surgery, I am very thorough of which limited mobility that you have, and we position you before you even go to sleep, and we never move you from that position. I tell my team, because during surgery, normally we passively move this and that, and I tell everybody, nobody moves anything. The patient's already positioned. And even after surgery, we never want to be in a situation where we emergently have to put a breathing tube down. So we have a special team that's ready to come up if anything ever happens, and they already know everything. So as you can see, it's a huge team. So as long as the team's already and aware, then I think surgery can be done safely for women with FOP. And so this is one case. We've done hysterectomy safely in women, and when done carefully without anything unanticipated or aggressive, they haven't had any heterotopic bone formation from our experience.
Yeah, I think it's important to recognize that it takes a lot, right? So, I mean, if you look at the list of authors here, this is not even half of the team of people who were involved in the care. And so we don't make such decisions lightly. We take them and we consult with people, you know, we consult with a lot of people before we make these decisions. But I think Dr. Park made a very important point, is that think long-term, what is going to happen in the future and how can we best address this? So thank you. This was really informative and helpful for me as well. So in terms of this, if this patient says, you know, I have this fibroid, yes, it's, you know, causing me some discomfort, but it's not that bad. And so what do we do if we just want to follow up those patients and monitor? What do you recommend?
Yeah, in general, we would say, well, you know, we go by symptoms, we do annual exams and try to feel the fibroid and is it growing or whatnot. And there isn't a general consensus on, you know, you have to get an ultrasound every year, or every 6 months. We don't really have that, mainly because the fibroids can be unpredictable in how they grow. They may be a little bit dormant and not changing, and all of a sudden over 6 months, they might grow quite a bit. And so it's hard to say, you know, every year and you'll be able to catch it before it grows. You know, we don't have that. However, for women with FOP, like I said, if we're always thinking about 4 or 5 years out, we never want to be surprised by something, and we don't want to be cut off guard in an emergent or urgent surgery kind of situation. So I would say it's very reasonable to, if you know you have fibroids and it's already sort of a decent size, maybe it's 4 or 5 centimeters, I would say let's watch it every year at minimum. Or if you have new symptoms or symptoms that are changing that indicate something might be changing inside too. But yeah, that would be my personal recommendation, just so we don't miss something or surprised by something.
Yeah, thank you. And so if on monitoring, when would you then switch to recommend any intervention?
Yeah, so if the symptoms are getting worse, and if we've already tried medical therapies and that hasn't worked, then we should definitely consider surgery. Like you said, surgery is not something simple, and takes a lot of coordination and work and a lot of discussion about risks and benefits. And so I think that's when we would consider, if the patient is ready and has tried other things and there's an appropriate team. And of course, when you're done with fertility, a hysterectomy is always an option. Even if you're young, if you never want to have kids, to me, that's fine. I take your word and we can do whatever you want us to do. So, yeah.
Great. So I think that ends our part of the discussion, but I see a lot of Q&A in there. So I'm going to start with the first one. So the question, maybe you and I need to answer that one, but is it safe to do a biopsy?
I'm not sure what biopsy you were talking about, but sometimes when people have irregular bleeding, we do an endometrial biopsy, which is a biopsy of the lining of the uterus. Oftentimes we know why you have the heavy bleeding. Maybe it's the fibroid or a polyp or whatever, but sometimes we don't know. And sometimes it could be something microscopic that doesn't show up on imaging. And so we do the biopsy, which means we sample it to make sure it's not something dangerous like precancer or cancer. Rare, but we want to roll that out. So in terms of a procedure, it's an office procedure. There isn't anything sharp. It's a biopsy that does go inside the uterus, that doesn't puncture anything. So I would think it might be safe, but I would like to hear your thoughts too.
Yeah. And so in terms of the biopsy, if it's going to be done in the office, there's not going to be any anesthesia or sedation, you know, and you're going through vaginally through the uterus to do a biopsy, that should be safe. And one thing to note, and I forgot to mention that earlier, is that the uterus is made out of smooth muscle. So even though it's made out of muscle, it's made out of a different type of muscle than what we have in our arms and our legs and the skeletal muscles. So it's not a muscle that is known to be affected by FOP. So we've never seen flare-ups in the smooth muscle. We're not worried about HO or development of bone within the uterus. So in terms of doing a biopsy inside the uterus, that should not be a problem. The issues that that might be of a concern is that based on your positioning, or if you're unable to do the biopsy through, you know, vaginally, then that might require a more invasive procedure that might go through the abdominal skeletal muscles, and that might be, you know, you might be concerned with having a flare-up or something of that sort. But all right, and then Is it included to check for fibroids in the yearly checkup, or how is it found out if it's mostly asymptomatic?
Yeah, so it could be found in many ways. So if I do an exam and I feel your uterus and I feel there's a little lumps or bumps, that might be indicated. So that's one way. If you have symptoms of anything, heavier bleeding, pelvic cramping, stuff like that, then ultrasound is usually our first go-to imaging, and that's another way we find it. So oftentimes we find it before the patient really has symptoms for other things if we get it and we happen to see it. But those are the ways we would normally find it on exam, and then if you're getting imaging for anything.
All right, so I have a question from a patient, and it's about her specific question. So I have never had menstrual cycles up until this year. About February 2021, I started having the cramps, irritability, and light flow. This used to rarely occur with me, perhaps once or twice a year, since my first cycle around age 12. I have uterine fibroids, and sometimes the pain is bad. Other months, the pain is minimal. Should I be concerned about these changes? My gynecologist says my blood work and transvaginal ultrasound do not show any concerns and no menopause.
Yeah, that's a difficult question. I feel like there's a lot in there, which can be from a lot of things, or maybe it's one thing. So, you know, so for example, let me just read again, cramps can be from a lot of different causes. Some things that may not show up on ultrasound. None of what I'm thinking is dangerous, you know, and by dangerous, I mean something like cancer or something like that. But if they're looking for something that they don't see on ultrasound, sometimes we do recommend MRI if the symptoms are severe and we're looking for things that may not show up, such as endometriosis, something like that. Mm-hmm. Irritability would be separate. You may just be getting more sensitive to your hormones, especially if your hormone levels are still normal every month.
Yeah.
And so it's not so much being concerned about something dangerous, but I think it's just important to always have a thorough workup, and you can still manage the symptoms, even if there's no problem that they're specifically finding. The symptoms themselves could be enough for you to warrant some treatment. So.
Thank you. Another question is, what is the difference between fibroids and a myoma?
There's no difference. It's just a different name. We have, just to confuse ourselves, we have fancier names and even more fancier names for the same thing. So fibroids, myomas, leiomyomas, all same thing.
All right, great. And so I think there was one question in the chat where it talked about how can you examine someone creatively when the hips have no abduction? I had an ultrasound one time, and it seems that it's the only way this could be done.
Yeah, I guess it depends on what we're trying to examine. So if we're trying to examine the vagina or the cervix, maybe doing like a pap smear or something like that, sometimes we can do it without opening the hip. So sometimes they can do it from laying down, and I can kind of do it from behind. So there are creative ways to look for that. If we're looking to examine the uterus, which is much deeper, then probably an ultrasound would be the least invasive way to do that. And the ultrasound can be done with an abdominal probe. So the probe goes through your belly and just kind of looks out without like an internal probe. If there's something more that I'm looking for, something on the ovary, then again, the next step might be an MRI, but probably an ultrasound will probably show us for most things.
Mm-hmm. Thank you. So another question I saw in the chat, sorry if I missed some of them because the chat has a lot of messages, but one of them was,
you're good. That was the only one that.
Yeah. So there's one more. Well, there's here that says here, my gynecologist thinks it's not necessary medication for a 7-centimeter fibroid because it's not giving me any major problem and no symptoms. It's recommendable only the ultrasound every 6 months or a year.
Oh yeah, so that's a good question. Kind of like what we said before, there isn't a guideline to how much we have to watch the fibroids, because like I said, sometimes they do nothing for years and all of a sudden they increase. And so even if we checked it every year, every 6 months, we might miss it until it's gotten bigger. So it really depends. I think what also, you know, if you had an ultrasound in the past before 7 centimeters, how big was it? You know, did it go from 2 centimeters to 7 within a year? That's a pretty fast change. Or was it 7 for a long time, right? And so, yes, usually we say if you don't have any symptoms, there's no reason to put you through unnecessary surgery to remove it or any procedures. But if it's something that went from 2 to 7 in a year, like I said, we want to kind of always think far ahead, and I don't want this to go from 7 to 14. which may make surgery more complicated. So I think doing nothing is fine right now, but I would probably recommend an ultrasound to just check on it.
Yeah. So I think as well, kind of to highlight a couple of things. Medications, again, will not decrease the size of the uterine fibroid. So if you're not having symptoms, medications are not really going to be helpful to decrease the size of the uterine fibroid. And I think but maybe just to answer that question, is there a certain size, Dr. Park, that you would say, oh, we definitely need to do something about it? Is there a size cutoff?
That's really hard, because I've seen women with 30, 40 centimeter fibroids, and they're fine and they don't want me to do anything. And that's fine, But in this population, if we're always thinking ahead, 10 centimeters where I would start thinking, hey, when should we do something? Are you starting to feel something? Let's just, even if it's something we're planning for the future, let's start talking. So 10 centimeters just would be a general cutoff for me.
Great, thank you. So I think there was one question before, and I don't think I see any other ones. So this is going to be probably the last one, but there was one question about how come some people have amenorrhea, some people don't, some people have regular periods. And is that something that we understand in FOP? And so just to kind of give you a whole overview, we really don't know. Some of the things that we encounter could be due to some of the things that Dr. Park mentioned, like chronic illness, low weight, but is the ACVR1 mutation causing any of these things? Do we know, is that directly kind of affecting some of these hormonal changes? We really don't know the answer to that question. The other thing that we don't really know is what is the scope of this issue within the FOP community? We hear of a lot of women having uterine fibroids. I get, a lot of people reach out to me with concerns of uterine fibroids on a regular basis. But we have incorporated now questions into the registry to really ask this, for us to really first understand what is the scope of the problem. How many of the FOP patients have uterine fibroids? How many of them underwent surgical procedures? What complications did they have? Did that affect their FOP disease activity? So there's a lot of unanswered questions. And I really think that the registry will be very helpful for us to first understand the severity of the issue, or is it more common in the FOP community versus the general population? We really don't have those answers right now. I think they told me amenorrhea because of the weight, 40 grams, but ovum and cervical pain, it gives me anguish 3 days. So I think this was a translated question, which is, I'm going to have to make some assumptions. They told her that she has amenorrhea because she has a low weight of 40 kilograms. But she has like cervical and pain for 3 days. And I'm not sure if we're going to be able to answer that question.
Yeah.
I was just checking to see if this person had submitted any other questions to build off of for this, and I don't see. So they may have just been providing more information about their situation as well. But
okay,
we will have slides and the recording of today's presentation available. Since you've registered, you will get an email with the link to those. And there will also be a survey. If you could complete the survey, I would greatly appreciate it. I'll also put a link to the FOP patient registry. As Dr. Mukaddam mentioned, it is a really great and very important way for the researchers and clinicians who are working on FOP to better understand the disease. So if you're not already enrolled in the patient registry, please take a moment to learn a little bit more about that and see if it's something that would be of interest to you. I will mention there is a $25 Visa gift card that reward that patients get for completing surgery. So if that's a helpful incentive, please do look further into that. And I just wanted to say thank you again to Dr. Mukaddam and Dr. Park. I know you guys put a lot of brain power into creating this presentation, and it was very thorough. and you've answered so many questions. I think for the first time, probably for the broader, for all of the, women in the FOP community to have a resource like this that's documented and they can go back to and reflect on. I think this is the beginning of, a really important journey that the IFOPA is going to be on to continue to provide education about treating the whole person. So thank you everyone for joining. A lot of thanks for you guys in the chats coming in now. So thanks to our panelists, and thank you to our attendees for taking the time out of your day to join us.
Thank you. And really thanks to Dr. Park. Yeah, thank you, Dr. Park, so much.
For letting me participate.